Optic neuritis is the inflammation of the optic nerve, and it typically causes acute, often painful, vision loss in one eye. It commonly affects young adults, especially women, between 20 and 45 years of age. Now here's what makes optic neuritis stand out. It's frequently the first clinical manifestation of multiple sclerosis, a central nervous system demyelinating disorder. So when you see optic neuritis, think beyond the eye. You're looking at a neurological window. Patients usually come in complaining of sudden vision loss in one eye. This vision loss progresses over a day or two and may reach its worst point within a week, but it doesn't stop there. Ask them this: does it hurt when you move your eye? If the answer is yes, and it usually is, that's a major clinical clue. The pain comes from inflammation of the optic nerve sheath, particularly where the rectus muscles attach near the globe. Another classic feature is color desaturation, especially for red. Red objects appear faded or washed out. Why red? Because the papillomacular bundle, which carries central vision and color signals, is highly vulnerable to demyelination. On examination, if one eye is affected, you'll find a relative afferent pupillary defect, or RAPD. This means that when you swing a flashlight from the unaffected to the affected eye, the pupil paradoxically dilates instead of constricting. This finding is central to the diagnosis of unilateral optic neuropathy. In terms of types, optic neuritis can be retrobulbar neuritis, where the optic nerve is inflamed behind the globe, and the fundus looks normal; papillitis, where you see disc edema; and neuroretinitis, which is characterized by disc edema plus a macular star, a pattern of lipid exudates. Let's talk about causes. In the West, the most common cause is demyelination, especially in association with multiple sclerosis. But we must also consider other possibilities: infectious causes like syphilis, tuberculosis, herpes, and Lyme disease; autoimmune conditions such as lupus or sarcoidosis; and increasingly, post-viral or para-infectious optic neuritis in children. Don't forget NMOSD and MOG-associated optic neuritis, both of which are more severe and tend to recur. Next, investigations. The most important test is MRI of the brain and orbits with contrast. This not only confirms enhancement of the optic nerve, but also looks for white matter plaques suggestive of multiple sclerosis. According to the Optic Neuritis Treatment Trial, or ONTT, if a patient with optic neuritis has even one white matter lesion on MRI, the 15-year risk of developing MS rises to 50%. Without any lesions, it drops to around 25%. That's a huge prognostic clue. Visual evoked potential, or VEP, shows delayed P100 latency, again due to demyelination slowing down conduction. This is particularly helpful when MRI is unavailable. OCT, or optical coherence tomography, may show thinning of the retinal nerve fiber layer later in the disease, reflecting axonal loss. Blood tests like ANA, ACE, VDRL, and aquaporin 4 and MOG antibodies are useful when atypical features like bilateral involvement, recurrence, or poor recovery are present. Now to treatment. The gold standard, as per ONTT, is IV methylprednisolone at a dose of 1 gram per day for 3 to 5 days, followed by a short oral taper. But here's a critical point: never give oral steroids alone without IV steroids first. Why? Because oral steroids alone have been shown to increase the risk of recurrence. Steroids help speed up recovery, but don't affect the final visual outcome. Most patients recover 6/6 vision in 6 to 8 weeks. But there are red flags that suggest a poor prognosis: no light perception at presentation, bilateral simultaneous involvement, lack of improvement within 2 weeks, recurrence, and association with NMOSD or MOG disease. Such patients need further evaluation and possibly immunosuppressive therapy. Let's not forget the differential diagnoses. Ischemic optic neuropathy usually affects older patients, is painless, and often causes an altitudinal visual field defect. Leber's hereditary optic neuropathy is painless, bilateral, and more common in young men. Compressive optic neuropathy tends to progress slowly and often has minimal pain. And toxic or nutritional optic neuropathies are usually bilateral and symmetric. Before we wrap up, one crucial part of managing optic neuritis is patient counseling. They need to know that vision often improves with or without treatment. There is a risk of developing multiple sclerosis, particularly with positive MRI lesions, and that further neurological evaluation may be necessary. For patients with a high risk of MS, referral to a neurologist is essential. Disease-modifying therapies like interferons or glatiramer acetate can be started to reduce long-term disease progression. If this video helped you, please like, subscribe, and share it with your colleagues.